Good afternoon. It is my enormous honor to welcome you to the third Jim and Sally Warden Parrott Healthcare Education Fund Lecture, made possible by the generous support of Sally Warden Parrott and Virginia Premier Health Plan. My name is Cindy Watts, and I'm the Richard M. Bracken Professor in Health Administration at VCU. The Jim and Sally Warden Parrott Healthcare Education Fund was created to endow a lecture series on the topic of the evolving environment of healthcare, with specific interest in better understanding the healthcare as it relates to vulnerable populations. The Parrott Fund honors the legacy of Jim Parrott, whose career in healthcare began as a high school healthcare educator and evolved to the senior-most leadership position at Virginia Premier Health Plan. The fund serves as a tribute to Jim's career and as a reflection of his passion for promoting and supporting the health of vulnerable populations. As we honor Jim's life and legacy this afternoon, I'd like to extend a special welcome to Sally Parrott and to her friends and family and the family members who were unable to be here this afternoon, but who join us in spirit. I also extend greetings from the College of Health Professions Dean Susan Parrish, who got caught up in some out-of-state travel and is unable to join us this afternoon, but she extends her regrets and hopes that you enjoy your time with us in our gorgeous new building. Finally, I'd like to thank Beth Williamson-Aries, who I think is still out in the lobby, along with Katie McCall and Paula Demrick for all your hard work organizing this afternoon's details. It's now my pleasure to introduce our moderator, who will introduce our keynote speaker. Linda Hines is the CEO of Virginia Premier Health Plan. She has a long history with Virginia Premier, having joined the organization more than 20 years ago as the Vice President for Medical Management, working her way to the COO position for 4 years before becoming CEO 3 years ago. Prior to her work with Virginia Premier, she served as a nurse manager for the VCU health system for 16 years. Ms. Hines is a 3-time VCU alum with a BS in nursing, an MS in nursing, and an executive MBA from the VCU School of Business. She's active in the community, having served on a variety of committees, including the Governor's Task Force on School-Based Clinics, and she is currently the Vice Chairman of the Virginia State Board of Health. Please join me in welcoming Ms. Linda Hines.
Good afternoon. I have the esteemed pleasure and honor of introducing our keynote speaker tonight, Dr. Bruce Siegel. And so we are so honored to have him here with us tonight. He has many, many accomplishments. He is currently the president and CEO of America's Essential Hospitals, which is the leading association and champion for hospitals and health systems dedicated to high-quality care for all, including the most vulnerable. Since 1981, America's Essential Hospitals has initiated, advanced, and preserved programs and policies that help these hospitals ensure access to care. They support their members with advocacy, policy development, research, and education. But enough about the organization. We want to hear about Dr. Siegel. Dr. Siegel, with an extensive background of healthcare management policy and public health, he has the blend of experience necessary to lead America's Essential Hospitals and its members through the changing healthcare landscape and into a sustainable future. And we all know that healthcare is really changing these days. Since joining America's Essential Hospitals in 2010, Dr. Siegel has guided the association toward realizing its strategic vision of helping members transform into integrated delivery systems and leaders in access and quality. America's Essential Hospitals also works to secure sustainable funding for essential hospitals which fill a safety net role in their communities. He has led the launch of the Transformation Center, a catalyst for innovative change to improve quality and safety, and a part of the Essential Hospitals Institute, the association's research arm. Through Dr. Siegel's leadership, America's Essential Hospitals established the nation's first safety net quality network under the Centers for Medicare and Medicaid Services. Dr. Siegel's intimate knowledge of member needs comes in part from his direct experience in this sector. He previously served as president and CEO of 2 member health systems, New York City Health and Hospitals Corporation and Tampa General Healthcare. His hands-on member experience provided a lens through which to view his research and policy work as director of the Center for Healthcare Quality. Also a professor of health policy at the George Washington University School of Public Health and Services. Dr. Siegel also served as New Jersey's Commissioner of Health. His accomplishments are very varied and many. I'll just highlight a few of those. He's led groundbreaking work on quality and equity for the Robert Wood Johnson's Foundation, as well as projects for the Commonwealth Fund, the California Endowment, and the Agency for Healthcare Research and Quality. He is current chair of the National Advisory Council for Healthcare Research and Quality and a member of the National Quality Forum Board. Modern Healthcare named him one of the most 100 influential people in healthcare, not 1 year, but in 2011, 12, 13, and one of the 50 most influential physician executives in 2012 and 2013. So please join me in welcoming Dr. Bruce Siegel.
Thank you, Linda. Can you all hear me fairly well?
Yes.
Good, fantastic. Thank you, Linda, for a very kind introduction. I hope you could just convince my daughters of my value. And thanks to all of you in the VCU family for hosting me here today. I also want to acknowledge the Department of Health Administration's long tradition of service to the Richmond community. I also know that Virginia Premier has shared in that spirit as well, as it works to make healthcare more accessible to all the people of the Commonwealth. Now, I know we're here in part to honor the life of Jim Parrott, and his life was in many ways a testament to that same spirit. He took the skills that he learned in herding cattle, advanced his career, eventually took the helm of Virginia Premier, and all the way time maintained its focus on those in need. Sally, I bet that Jim found herding to be an incredible skill and useful to him as CEO later on. So we're indebted to his memory, and I'm glad to be a small part of that remembrance, so thank you. So I know that we're in a leading university here tonight in Richmond. This is an educational meeting, and everyone is here to learn, in addition to meeting old friends and new friends. So I thought, since I was a former, I guess I still am, faculty at GW, that I'd be somewhat professorial in this. So this talk is apparently worth something like 50 ACHG credits for all of you. I knew this crowd. Or at least I think it should be worth that much, okay? So to make that real, there will be 3 quizzes in the course of our discussion tonight, and you will be tested. Now, VCU has been clear through your president and others about embracing diversity and inclusion. So being asked to talk tonight about equity and health equity seemed like a natural thing to do. But frankly, this would have been an easier speech a few years ago, when we thought that progress, though uneven, was still assured. But now it's a lot harder. In that time, in those few years, issues of equity, discrimination, and inclusion have been thrust to center stage. Charlottesville, El Paso, and yes, Walls have forced us to reassess not just our history, but yes, our assumptions about the current day. This debate has also raged in our world of healthcare. Often the language is technical or obscure, but make no doubt about it. The arguments going on now about healthcare reform and things like Medicaid expansion, including here in the state of Virginia, are arguments also about equity and justice. The promise or denial of equity has always been woven into the tapestry of social policy. It has been true in how we decide who gets to live where in our communities. We've seen it in how we decide who gets what kind of education in our country, and we see it in decisions being made today about who will be fed in America. It's the same in healthcare. Health disparities are a manifestation of this denial of equity. I'm thrilled that today healthcare organizations are committing to closing these gaps by trying to build diverse leadership, diverse in race, gender, ethnicity, sexual preference, and so many other things. Institutions and plans are striving to eliminate disparities of care while also confronting and changing the social determinants of health. And they're willing now to have a real dialogue about how unconscious biases affect how we treat our patients. Earlier this year, many of you may have seen that Modern Healthcare launched its Breaking Bias series, focused on diversity and inclusion. It has taken on some uncomfortable topics around the role of our health system and healthcare system in sometimes fostering inequity. And it's not an accident that this series was launched by their first editor of color, Aurora Aguilar. Sometimes the fastest way to refocus a conversation is to bring new voices to the table. But tonight, I'd like to shine a light in a different direction. It is good that we work in our institutions and maybe in our souls to create a culture of equity. But in the current national climate, we better remember something. Disparities have deep, tenacious roots in decisions this nation made about social services and the safety net. As we debate who deserves Medicaid or whether to expand Medicare, we better recall that these programs were designed to address many disparities, but also to leave some untouched. If we forget that history, we may doom ourselves to merely repeating it. Over 80 years ago, Franklin Roosevelt signed the Social Security Act into law. It responded to a nation in which millions lived longer than ever, but for whom old age meant poverty and dependency in the midst of a Great Depression. 5 years later, retirees in America for the first time began to receive monthly checks. The elderly finally had some form of safety net. But let's take a closer look. While we applaud our Social Security system for the old, we forget that when it was created in the 1930s, it excluded agricultural and domestic workers. Why would these two groups be consciously carved out of our national social insurance system at its outset? Well, because of this, millions of Hispanic and African Americans were left out of Social Security. It was the political compromise between FDR and Congress to keep Southern and Western Democrats on board with the bill. 65% of gainfully employed African Americans worked in the agricultural and domestic sectors of our economy in 1930, meaning that 2/3 of employed African Americans were barred from Social Security when it started. Inequity was written into the very basis of our nation's first comprehensive social insurance plan. 30 years later, we expanded health insurance coverage for millions of Americans with the creation of Medicare and Medicaid. It was a great achievement and a huge advance for health equity. Indeed, it was the rules of the new Medicare program that finally forced the integration of America's hospitals. Title VI of the 1964 Civil Rights Act threatened to withhold federal funding from any hospital that practiced racial discrimination. This meant any hospital that was segregated, and there were 1,000 of them in the United States in 1965, could be excluded from Medicare participation. This, along with an army of 1,000 volunteer compliance officers, forced the desegregation of every hospital in America within about a 5-year period. And we should be proud, as the expert who's written the most about this, D.B. Smith at Temple, noted, that today, as a consequence, hospitals are the most racially and economically integrated of any private institutions in our country. It's a great history, but one often forgotten, and forgotten really by people who often should know better. So let me tell you a short story. About 22 years ago or so, I served as CEO of Tampa General Healthcare in Tampa, Florida. It was a very turbulent time for us there, and one of our controversial initiatives was converting our county-owned hospital, looked a lot like VCU in terms of scope and scale and services, to a 501c3 nonprofit. It was what I would call a once-in-a-lifetime experience, never ever to be repeated. So, at the outset of our campaign for the conversion, we ran a big 2-page ad in the local papers. We wanted to fight some misperceptions and misinformation about what we were doing with the conversion. We wanted to share our belief that a new governance model would translate into better access. So, here it is, our ad. It was our honestly felt reassurance to the community that we'd be there for them no matter what. We actually found this about a year ago or so in old archives on microfilm, if any of you remember that, of the Tampa Tribune, which is long defunct. It was April '97. Now, it's actually a really bad ad. Right? You agree, right? I mean, first of all, the type is way too small. You need a magnifying glass for it, right? And then that image of the Tampa skyline at the bottom there kind of looks like, after the nuclear bomb goes off. That's what it looks like. So anyway, but I want to hone in on one thing in the text here, and that's this, because there's a bigger problem. What this box says, this is in the text here, above all, this is about our conversion to a C3 status. It will ensure that all the people of Tampa will have the finest medical care possible. It's the same promise we made over 70 years ago. That's when the hospital was founded back in 1927. So here we were, telling the people of Tampa and West Central Florida that their hospital would care for all of them just as it always had. So, question number one, for 20 credits. What could possibly be wrong with that text?
The word all.
Go ahead, sure. What's that?
The word all, like all the people.
Right, and there's a history of that.
Who was excluded during those 70 years? Who was excluded?
So, great responses. Tampa General, and I should have known better, was for the first 40 years of its existence a city-owned, segregated, all-white hospital. Black Tampanians were relegated to the inferior, overcrowded Clara Fry Hospital. There was absolutely no promise of equal treatment when Tampa General was founded in 1927. And I, as the African-American CEO, should have known that history a little bit better. So, by the way, to all of you future CEOs in the audience, let it be one lesson to you. Always read the ad copy before it runs. Okay? If you take anything away from today, take that away, okay? And there'll be more of those lessons to come. So, to be clear, VCU shares some of this history as well. Right here, the Medical College of Virginia operated the separate black St. Philip Hospital until the early 1960s. So I think you'd find that in many institutions across America. So let's take a closer look at the progress we made in 1965. While millions of Americans gained coverage that year under Medicare and Medicaid, we also created two very different government health care programs. Medicare, a purely federal program with eventually, universal care for the elderly, and Medicaid, a state-based program with an uneven patchwork of coverage for the poor, often minority mothers and children. Neither of these decisions were accidents, and they reflect the compromises we've often made in seeking equity. For the elderly, we created close to a universal entitlement for health care with clear, tight, centralized federal rules. Poor, browner people, mostly women and children, got a much less regulated system, frankly at the mercy of the states, with lower payments, sometimes wildly varying coverage, and little guarantee of access. Equity and inequity were both codified in these programs. 45 years later, the Affordable Care Act tried to mend these defects, and it made some great progress. But the Supreme Court, in its ruling on NFIB versus Sebelius, blew a hole in this, upholding the law but saying that Medicaid expansion was optional for the states. That hole is still 14 states wide today. Huge swaths of America, including Florida and Texas, with their big, diverse populations, can legally deny Medicaid coverage to millions of the working poor. Yet despite this, we still saw huge increases in equity, especially as millions of Hispanics gained coverage. And then came repeal and replace, attempts to repeal the Affordable Care Act. Now, I'm no newcomer to politics, and I have few illusions, having worked in New Jersey, about the practice of politics. Never been indicted, though. I only asked to wear a wire once, and that was in Florida. Said no. That's a real story, but we can talk about that in the Q&A later. But I'm still flabbergasted at how our elected officials sought to cast millions of Americans off the insurance rolls by repealing the Affordable Care Act. Why would they try to do such a thing? So for our next question, here we see our leaders celebrating, turns out prematurely, passage of repeal and replace. Some of you may remember this picture. And by the way, as you can see, it's a very diverse crowd. You have
Maybe by 10 years.
You have white shirts, and you have blue shirts. You have blue ties, red ties, even striped ties. But what about this legislation was so compelling? Why did they just have to pass it? So I go back to my training as a physician long ago, and I think of it clinically. Do you know what those are? Very good. You're the first person who's ever gotten that in the first shot. Are you a nephrologist?
3 years of fellowship.
This joke always works, except when there's a nephrologist in the audience. So Congress started repeal and replace like kidney stones. They didn't care what was in it; they just needed to pass it. I wish that was a joke, but it's really more. So when we talk about repeal and replace, which has never been funny before, what it's done, we talk about it. Let's think about what it would have done for inequity. And it's not just about coverage, if you repeal the ACA. Most people, including a lot of experts, don't realize that the Graham-Cassidy repeal and replace bill would have allowed HHS, this was hidden in it, to waive the anti-discrimination clauses of the Affordable Care Act, Section 1302B, to be precise. So what is that? That clause prohibits discrimination in insurance issuance based on age, disability, quality of life, expected length of life, and other things. It also says that benefits should consider the healthcare needs of people with disabilities. Repeal and replace would have repealed those clauses and opened the door to frank discrimination, overt discrimination in insurance markets. That was tucked right into repeal and replace legislation just under the radar screen. Repeal of the ACA would have been the greatest assault on health equity in our lifetimes. Period. Full stop. So thanks to the voice of many, and many of you in this room, you stopped it, and we stopped it. But we can't be complacent. There have been further runs on the ACA, and we know there's probably another case headed to the Supreme Court to decide whether or not the ACA is constitutional coming out of Texas. So we're not out of the woods yet. And even if the ACA survives largely intact, we also need to know that disparities are still with us. The ACA by itself won't end them, and Medicare for All won't do that either. Some of our most sincere efforts to improve quality, which are good things, could actually worsen these gaps rather than close them. And let's talk about one case. I am really glad we're now meaningfully measuring quality in America. I think we're still very much in the early stages of doing that, but it's the right thing to do for our patients and for us. One of the most highly known forms is the CMS star rating. It has a lot of imperfections, but I'm most concerned about how it lacks any adjustment for the social risks faced by patients. The literature is full of solid evidence that many outcomes measures, like readmissions, are heavily driven by the economic and social circumstances of our patients and their communities. We need to address those circumstances and address unstable housing, food insecurity, and so many other things that accompany poverty and racism. We need to heal our communities and make them better places. But we also need to grasp that measurement systems that ignore the reality of this torn fabric of our communities will punish those hospitals, those health plans, those neighborhoods in the greatest need. Penalizing a cash-strapped hospital for readmissions or other outcomes that are driven by that need will help nothing. Will only starve the safety net while sending a signal that there are places in America that providers should avoid rather than embrace. And then we have this, an explosion of ratings and measurements of varying validity, sometimes from a black box, giving consumers contradictory information on what treatments to get where. It's confusing. It's a disservice to our patients. But it may also foster rather than mitigate disparities and inequities. When there's uncertainty about what to do or where to go to get your care or what kind of care to get, patients and professionals make decisions based on biases and personal expectations instead of sound science. And complicated systems like this will only be navigated successfully by the most educated and affluent consumers. I am thrilled that we want to give better, real information to help consumers make better choices. Let's make sure that we provide them with the most useful information and information that all consumers can use to make educated decisions about their health care. Now, all of this brings me back to an earlier part of my career, when I had the honor of being the health commissioner for New Jersey, as Linda mentioned earlier, and serving in that garden spot of the Garden State, Trenton. I'm sure many of you have probably seen this on the Amtrak going up to New York or something. While I was there in Trenton, early in my career, I learned two lessons. And the first lesson I learned, and I'm going to digress here for a minute, was to pick your press secretary carefully. And let me tell you a story. So I was the newly inaugurated Commissioner of Health for the state of New Jersey, and the gentleman taking the picture here will appreciate this story. And we had a local paper called the Daily Trentonian, which specialized in or pointing a microscope on the deeds or alleged misdeeds of state officials in Trenton. And every state employee read that paper every day. So, my staff knew every scandal that was implicated in all the time. Bruce Siegel is selling certificates of need again. Anyway, or whatever. So one day the Trentonian called up our office and said, we need to do your initial interview as a new health commissioner. And I figured, but I have to do this. So the Trentonian came in and he said, oh, by the way, we want to take some pictures of you so that we'd have a stock photo of you to use when we run articles about you. Okay, so I had a reporter come in with a photographer. And mind you, this is like 1993, I think, or 92 or 93, before digital cameras. And so this was filmed. And so during this about 45-minute or so interview, the photographer took hundreds of pictures of me from every conceivable angle. And I got more and more nervous about where this was headed. A few days later, the first article ran using my new headshot, and you can imagine what that was. That was me. So, New Jersey, meet your new Commissioner of Health. Which brings me to the next CEO lesson: when things go bad, fire your press secretary. So all kidding aside, though, I also learned something else back in that job, and that there was a huge distrust between public health and healthcare. I talked to some of you about that during the very pleasant break we had before this. Hospitals and health systems, frankly, doubted the capacities and competence of government agencies, while public health doubted the motives of hospitals. It was a frustrating, ongoing conflict that did little to improve the health of people in Camden or Cape May or Jersey City or Newark. And I guess on some level, I'm still frustrated because much of this continues. But in other ways, and here's the good news, the world has changed as the economics and expectations of health systems have moved. Today, we actually are having real conversations about disparities and their roots in social determinants, as well as ignorance and bias. Today, population health is starting to have real meaning. And doctors and hospitals and others no longer say, hey, it's not my problem. Instead, many are asking, how did we contribute to these problems? And what's our role as an anchor in the community that seeks to heal and create health in all things? And today, people now realize, most Americans, that what they have at stake in government programs like Medicaid and Medicare. That's a real slide, by the way. Today in Virginia, hundreds of thousands of people who weren't covered before are now covered by Medicaid. That victory for equity took 5 years of struggle to achieve. I know many of you in this room fought to make it happen, and you should be proud of what you accomplished. And your efforts are now part of a larger national debate about whether this nation will join the rest of the developed world in guaranteeing health care for everyone within its borders. I don't know what the outcome will be of that debate, but I'm sure glad we're having it. So call me an optimist. Maybe I'm just a fool, but we've come a very long way since the days of St. Philip's and the unfulfilled promises of past decades and centuries. There will be more obstacles, there will be a lot of distractions, and we will make some big mistakes along the way. But I don't think we're going back to the 1930s or 1960s. Our nation is too different from what it was in those eras. The path will not always be clear. We are going to see some big setbacks along the way, but we are on the right path, headed sometimes shakily, but still in the right direction. As a great leader, who I don't need to tell you who he was, once said, the arc may be long, but it does bend towards justice. Thank you for having me here today. Thank you for letting me be a part of this celebration of Mr. Parrott's life. And thank you, VCU and Virginia Premier, for all that you do for millions of Virginians. Thank you, Cindy.
We have some time for questions. I have a microphone, and I'm not afraid to bring it to you. Who has a question?
Good evening, and thank you for your remarks. When you began, you talked, you talked about how we made progress, and you showed progress there. And so I wonder if you expect to come up and just speak to issues around national policy, where you see progress being made, and where not. And this is not a question about the next president. Yeah, there is an influence there. So could you speak to that? You know, what do you see in front of us in terms of the policy, weak spots, and what should we think about as health leaders?
So I think it's a mixed bag. So I think we've made, as I mentioned, great progress with putting ACA in place, which, believe me, has lots of imperfections. It wasn't truly universal health care, that we know all too well now. I think in some of the states that have moved forward with expanding Medicaid, we're seeing progress taking place. Virginia, for instance, other states as well, like Maine. Referendums again and again. But I'm worried that we're falling back in other places. Number of uninsured in our country is now going up. That's a terrible shame. That shouldn't be happening. And at least some of the data we're starting to see in the last week or two points to that may be a result of immigrants avoiding Medicaid. As we talked earlier, some of us earlier, that there's regulations now from the Department of Homeland Security you may be denied that if you get on Medicaid. You may be deemed a public charge. And this is going to be litigated, but it may be now leading to a serious rollback in those who are covered. So I think we're in great danger currently of losing the gains we've had so far. To me, the spot, regardless of what your political affiliation is, that the discussion is being, is a big part of this coming electoral season. What will the solution be to that? What will that look like? And I think, at least in that level, we feel to see that happen. So in the short term, afraid we're losing ground. In the long term, I hope we can continue to advance.
And thank you.
Thank you so much.
Oh, I can project.
Based or populist. Wellness education.
So, everybody's talking. And we're told it's imminent.
There's always enough. As you know,
To take over some of those hospitals. My theory is, been well documented. Everything. And, and then, so you went into ER and boom, you didn't realize you had gone to Oh, yeah, sure, yeah, so this is great. So, I got, as it's, these things happen.
Another question right here. Thank you. Hi, I didn't know other than.
So, I know something else. About some of the work going on at VCU. To refer people to social services. So I think there's even beyond just envision ourselves sustainable energy solutions.
Okay. So, as a very small token of our appreciation, thank you so much for being here. Please join me in thanking Dr. Siegel.